Hello and welcome to HFMA Talk, the podcast for NHS Finance. I'm Sarah Day, Policy and Research Manager at the HFMA. In this episode I speak to Maureen Edwards, Director of Finance, Estates and Capital Planning at Belfast Health and Social Care Trust, to understand more about the impact of Covid-19 in Northern Ireland and the difference it made to be tackling the pandemic as an organisation that delivered the full range of health and social care services. So, hi Maureen, thank you so much for having time to talk to us today.
Hello Sarah, lovely to speak to you.
So, could you start off just by telling us a bit about your trust and the sort of services that you deliver?
Okay, well Sarah, there are five fully integrated trusts in Northern Ireland, acute and community and social care trusts, and we also have a regional ambulance trust in Northern Ireland. Belfast Trust, which is the trust I work in, is the largest of these trusts, and we have 4 acute hospitals, 2 community hospitals, and we provide the full range of local and regional hospital services and also complete community and social care service, including children's community services, learning, disability, and mental health. In Belfast Trust, we deliver integrated health and social care, as I said, to our local Belfast population of about 340,000. And then we also provide the majority of regional specialties. So we have cardiac surgery, neurosurgery. We are home to the regional children's hospital, dental hospital and cancer centre. And that serves a population of Northern Ireland, which is about 1.9 million. Our annual budget is around £1.6 billion. And we have around 21,000 staff. We also have the major teaching and training hospitals in Northern Ireland. We also, alongside our acute care, we support around 7,500 people in their own homes. Almost 2,500 residents are cared for in trust, domiciliary or statutory sector or independent sector care homes. We are responsible for 350 children here in Belfast Trust on the Child Protection Register. We have 750 looked after children and we manage that. And we have around 4,000 children and young people in need. We also have around 140 partnerships with 1,000 plus contracts with the community, voluntary and private sector organisation. And we get through our business with the support of around 400 volunteers. And we never forget around 40,000 family carers who without whom we couldn't do our services really. So I suppose that maybe gives you a flavour of what we do. On the acute side, we have 160,000 annual attendances at ED and we have 150,000 inpatients, 600,000 outpatients. So it sort of gives you a bit of the scale of our trust, and we're spread out across the city. We have an estate worth about 1.2 billion. So pretty big, integrated, as I said. The only thing I suppose that we don't do really in trust here is primary care, though we are developing better relationships with that side of the sector.
It's really quite vast. So obviously we're talking to you today because of coronavirus, COVID-19 and the impact that it's having for people in various parts of the UK and different sectors. So I wondered if you could give us a bit of context around the Northern Ireland impact of COVID-19 and then perhaps go into a bit more detail about what it's meant for Belfast.
Okay, I suppose just some high-level figures that you've probably seen on the news. In Northern Ireland here, we've had approximately 4,700 confirmed cases of COVID, and we've had approximately 525 deaths, over half of which have happened in care homes. In Belfast, we account for about 190 of those deaths, and again, around half have been in the community. I suppose in the rest of the UK, and I know your other podcasts, COVID has been an evolving picture here, and trusts and the ambulance trust and the public and our staff have had to adapt. We've had to redesign. We've had to act rapidly and regularly just to move with the changing circumstances. And my overwhelming sense is that our staff have done that willingly. They have done it despite the uncertainty with great conviction, and they have been empowered and they have been very successful despite their own personal concerns, and there are many, and we all know that. I mean, in hindsight, because of lockdown and social distancing and all the measures we put in our hospital sites and our community and the public themselves, we haven't seen the demand that we were predicting, and we haven't had to put our full measures in place, which obviously is fantastic. But I think there's a real sense of pride that we know we were prepared for much worse, and we were ready. And, you know, we could have done more if need to be. And I think that is a real sense of pride. And it's humbling really to see how staff have risen to that challenge. In terms of our own trust, we began planning at trust level, but also conscious of a regional planning need. And we've tried to be consistent in our approach across Northern Ireland. But we started that planning at the end of January. And our surge plan obviously fed into the regions. Phase 1 of the plan, we had our first patient on the 26th of February, and they came into our infectious disease ward in the Royal Victoria Hospital in Belfast. And then as numbers, we knew that numbers would grow, we designated one of our smaller acute hospitals. So we would have two. We have a very large Royal Victoria Hospital with a large ED department with about 300 attendances a day. And we have a smaller acute hospital also in Belfast where there are attendances of 70 to 80 ED attendances a day, and it provides a full range of medical and surgical specialties. We designated the Mater, that smaller of our hospitals, as our COVID centre. That meant that staff and services had to grow, had to change. We had to move some of the services. And we also then had to move staff and train staff to move into the Mater Hospital. Respiratory and ICU services were expanded. The ED on that site then was designated as a COVID-19 ED, and then our other ED was for non-COVID patients. And the Ambulance Trust worked with us to make sure that the COVID patients were referred to there. When we realised then that numbers would increase because we only had capacity for 14 to 16 ICU patients there, we then set about in our Belfast City Hospital. We designated that as our COVID hospital, and we started to clear 8 floors of that hospital. So that involved a lot of staff transferring out to other units. We had downturned elective care and etc. to allow that to happen. At the same time, other trusts in the region were expanding really just marginally their ICU bed capacity, but our city hospital was soon designated as the Nightingale Hospital for Northern Ireland, and we'd increased our ICU capacity there from 11 to a maximum capacity of 230, although, as I said, thankfully we've never reached those levels. That hospital reconfiguration, testament to my staff and estates and a whole host of staff across the trust, purchasing ventilators and oxygen generators, repurposing wards, clearing out services, and that all happened in about 2 weeks. So alongside that then, and I should say the Nightingale Hospital, we took the decision 2 weeks ago to close the Nightingale Hospital because we haven't had the demand that we needed. So our ICU capacity across the region is sufficient for now. We have kept 100 beds in that hospital free so that we can react very quickly to a second surge. Alongside the Nightingale Hospital, we commissioned the repurposing of a city centre hotel. You're conscious, we're a bit different in that we have the whole community and social care side of the house, and a local healthcare provider worked with us in partnership to repurpose a hotel to become a step-down facility so that we could discharge patients from hospital. It was set up for patients who had a COVID positive diagnosis and were in the recovery phase of their illness, but they couldn't go home, and we didn't really want to keep them in a COVID hospital, so that allowed us to step them down.
And did you use that very much? Have you made use of that capacity?
Well, like the Nightingale Hospital, I suppose it hasn't been used extensively. And there was capacity in the hotel, and it was prepared for up to 150 residents. We imagined there might be 60 plus residents at any one time at the height of the surge. We've actually only peaked at about 23, and those numbers have been falling. So we took the decision last week to stand down the hotel, and we will vacate patients within the next week. And that, but there has been good learning from it as a step down, and I think what we've taken from that is that we do need some sort of step down facility in our trust, because to aid discharge, because we have suffered over the last couple of winters with delayed discharges. So we've taken some learning from that. And another element I just wanted to mention was a GP COVID centre. So at the end of March, we established as a region a number of 7-day primary care COVID centres, and they are, one in Belfast is based in one of our wellbeing and treatment centres, and that took a bit like the hotel and the hospital 4 days, I think, of planning. So things that would ordinarily take months of planning, months of implementation, 4 days, we had that in place, and it opened on the 1st of April. So it's run by a team of senior community nurses, and they facilitate a number of GPs, and then other GP practices refer patients in. So we have about 50 patients a day probably referred into the COVID centre, and then the GPs decide on appropriate treatment and pathways. We have probably seen around 2,000 contacts, 420 people have been referred from those COVID centres to the hospital, and about 125 have been admitted. So that, I suppose, gives you a bit of the sense of our journey. I suppose what I would say now is that we have now begun to move out of our COVID planning and our acute hospitals planning, surge planning, and back to, our focus really on trying to move towards a gradual normalising of services, whilst remaining prepared for that second surge. So we have noticed over the last couple of weeks, for example, our ED attendances are back to really pre-COVID levels. And that obviously presents us difficulty in terms of social distancing, but it's a sign that things out in the public are moving a bit back to normal, and we need to now to catch up. So, like other trusts in the UK, at a very early stage, we stood down elective care, and we were really only doing, until quite recently, emergency cancer work and other critical surgery. The IS have been, really, fundamental to having done that, because we have clean IS centres, for example, for radiotherapy and chemotherapy.
And IS is?
In the independent sector, private independent sector providers. In the last couple of weeks then, we have, I suppose, switched on some of our priority 1 and 2 cancer and urgent surgery work. And with the closing of the Nightingale Hospital, and that's allowed that to be happened. But we are very conscious that we have to do this slowly and in a planned way because of workforce and PPE issues, and also conscious that we may have to rapidly turn things on again as the lockdown has been relaxed. So we all trusts 2 days ago, all trusts in the region had to submit restart plans to departments. So this has been regionally led, and we are taking a fairly cautious approach, but we're always conscious that there are patients out there with time critical needs, and that we need to get the right balance. So all of the, our full range of services included that example day centre. So there are plans for June, and then we're moving into plans for the summer across the range of services about what can safely be restarted.
So there's a few things there that you've mentioned that I'd like to pick up. And first of all, you've mentioned about how quickly things were organised and changed as you needed to set up new services. Obviously, that happened because there was the urgent need, so everyone was working together really well. But do you think there's something you can learn from that in terms of your future processes for implementing service transformation and doing things differently?
I think absolutely there has been huge learning, huge empowerment. When we have started to implement collective leadership in our trust a couple of years ago, and we have what are in most of our directorates triumvirates with a clinical lead, a co-director who's a manager, and a nurse, divisional nurse, and those have been working well, and in different teams that's developing at different paces. During COVID, those teams come into their own. The empowerment at frontline was overwhelming, really, and decisions were made very quickly. And people have been enthused and motivated and have really, enjoyed making those changes. And I know we're getting a lot of feedback from the trust. Why can't this always happen? Why can't we cut out the red tape and the bureaucracy? Yeah. And I suppose we have to find the right balance. I think there is learning. There is a bit about why does it take us so long? Why don't we try more small tests of change and review and assess and go back? We're sometimes a wee bit cautious in doing new things, and we do tie ourselves down a bit. But at the same time, we can't have people going off procuring on their own or starting up services. We do have to have some level of governance, financial governance, clinical governance, and it's getting that balance right. But I think there's a real appetite to build on some of those successes and some of the relationships that have formed inside the trust and also outside. We have mobilised a number of partnerships that we would be really keen now to, at some pace, develop in the future.
You also mentioned about delayed transfers of care and how you realised that the step-down facility that you set up temporarily was really helpful. Obviously, in England, social care is separate, but people have reported that relationships between health and social care have really improved, and that's partly been around that delayed transfers of care and the working together. Obviously, social care also comes under your trust remit. So have you seen an impact on social care, and have things changed between the health and social care parts of your trust in order to deal with COVID-19?
Absolutely, because there has been change to all of our services. And in the community, we've probably seen a bigger change because, as I said earlier, the care homes have been particularly badly affected because of the client group there, really. So we have responded, I think, very quickly to the needs of the care homes. We, at an early stage, moved in to help the independent sector because whilst we're an integrated health and social care system, the majority of our care homes are operated by independent sector private providers. There were problems at the start with staffing. There were problems with PPE. Now that was very quickly resolved because the trusts now purchase PPE for all the care homes where our patients are. But, we were conscious that they needed our support. So, for example, back in February, we started to test patients in homes that we provided the testing, and we then rolled out the testing of asymptomatic patients and staff in homes that were designated as green. We also started testing in April all of those patients who were going to be admitted or who were returning from a care home. We have provided considerable support to the care homes, including, for example, in the last month, we have redeployed a number of registered nurses to the care homes to support them where their staff have been off or to lend additional support. We have sent multidisciplinary teams in. So we have our care of the elderly, medical and nursing teams have really developed and grown their acute care at home models to strengthen our ability to respond to referrals. We have a daily virtual ward round for problematic patients in care homes by the Trust Care of the Elderly team. And they have the ability then to review or look at different treatment plans. So we have a lot of multidisciplinary supports. We have sent in specialist respiratory nurses, for example, palliative and end of care, end of life consultant advice and training, and we've had GPs from the COVID centre help out there. So psychological supports we've offered them too. And then even in terms of finance, there was a real concern that homes, because of vacant places and because of staffing pressures, that some of the homes would become financially unviable. So there were regional guidelines put in place, and we are now making sure that we pay care homes so they receive probably around 90% of pre-COVID monthly income to make sure that there's a continuous revenue stream there. We have also now very recently, we have provided grants to some homes too. We're also now going to provide assistance with cleaning and equipment requirements in the homes, and also with their sick pay. So a lot of support, practical support in terms of staff, and support from, professionals in the trust sector, and also then that financial support.
So it sounds like it's really improved relationships and developed the closeness of working between the two sectors, as it were.
I think absolutely. And I think there is already a review of the whole care home sector commencing. And I think we need to build on some of the learning and what support is needed. How can we best work as a system? And on all of those other elements that feed into that, I mean, discharge, or, dementia. There's a need for more, I think, care of patients with dementia. Do we need to look at specialist areas within homes? So there's an awful lot of work, I think, that will come out of this, and a lot of learning. And as I said, we have built partnerships now, and I think the care homes, they've seen that the trusts are there to support them when they need it. And I think that will start a more trusting relationship.
So you mentioned the financial support that you were able to offer for care homes, and I'm interested in how the funding arrangements have changed generally across the health sector in Northern Ireland to support COVID-19 and the extra expenditure that you've had.
Well, the Department of Health and within the last month allocated their budgets for 2021, and there is a significant pot of money for COVID-19 specifically. Whilst it seems like a considerable pot, I think we've had initial funding of £205 million for the region, and another 150 just specifically for PPE. While it sounds a lot, we know that spend in the first couple of months has been significant. So I suppose, like the UK, I mean, this is going to make a considerable dent in the funding for the Department of Health this year. We have a process for submitting proportionate business cases for COVID spending, but there a lot of the red tape has been relaxed because people are conscious we have to make rapid decisions. There is obviously good, robust decision making around it, but we're going with the information at the time, and assumptions and assertions change, and we know that. PPE has, costs have been huge, and again, that will be no surprise to anyone listening. We've had 1,600 times the prices of pre-COVID PPE, and usage has been 2,500 times or more, and I think that is rising. We've had considerable estates costs because I mentioned there the repurposing of our Mater Hospital and then our Nightingale Hospital. We've had to repurpose wards in other areas for to keep some of the hospitals as clean sites. So there's been a lot of estates work. There's been, trying to get our ventilation and oxygen supply up to scratch. So considerable spend in that area. And then we've obviously had spend associated with free car parking, accommodation, food, etc. for our staff. So a range of costs. We have them all well documented, and that's a new job for finance, really, just to keep a tight handle on that, because with all this speed and spend, the pace of change, we need to make sure we have tight control in terms of governance, that we document any deviations from normal practice, etc.
So what have your finance team been doing during this time in terms of working practices? Have they all been working in their normal offices or doing some home working?
Well, most of my team, I have to say, are still actually in work, because we have a bit of a capacity issue in our trust with remote access, and as a finance team, we try to prioritise that access for clinical staff. So apart from those shielding or those who are more vulnerable or are over 70, for example, most of the staff remain in work. Now, that said, we have adapted working patterns, we have shifts, we have people coming in at weekends, we've changed room layouts, we've taken over some of our meeting rooms, for example. So, we've ensured that staff are safe, but where people can work from home, maybe if they can't, they might not be able to access the finance systems, but where they are working from home and don't need to do that, we are obviously keen to let them do that. In terms of what they are doing, like all of the trust, I think across the trust, they've been exceptional in their willingness to help out, to take on new roles. We have had final accounts, and that went very smoothly. But alongside that, a number of our staff have been redeployed to other areas. I mean, the key areas are in managing donations and helping the team that. But I suppose where most of the staff been redeployed, and they're not huge numbers from finance, they have joined governance teams and other teams in managing stores. So in Northern Ireland, we have a centre of procurement expertise. We have a procurement and logistics centre, and they procure for all of the trusts. But as in the UK, where we have the items in short supply, the PPE and other items, our procurement experts have pushed those out into the trust. So we are managing the receipt and distribution of those products, and they are in their millions. And our staff don't have the training, and we had to find storage for that, but they have leapt at the opportunity and pulled out all the stops, and that has been very successful. I just suppose, like everybody else, they have just been exceptional in response. I also manage estates, and they obviously have been working, across the working week at all hours to get things up and running in super fast time. So again, I'm very proud of what they have been, done for the trust, and certainly there's real sense now from them that they, sometimes support services in the background, they very much came to the fore. And I think that has been very rewarding for all of our staff.
So obviously it's been a difficult time for everybody, and I'm wondering what your trust has been doing in order to support your staff through this and support their well-being.
Well, as with all trusts and everybody in the NHS and the public, this, I mean, our staff are our highest priority. And as I said, they have been outstanding in their response to COVID. And I think there is a real sense in the community of the value of our staff. In terms of our successes, I think we have been very responsive as a region and as a trust. Testing, for example, we very quickly increased capacity in our testing. So I think we were able to do 300 odd tests per week. We're now up to around 10,000. And for all of our staff who have symptoms or who have families who are symptomatic, we guarantee them that if they want, and we would encourage them to have a test, that would be done within 24 hours. And the turnaround time for that is usually 24 to 48 hours at the most. Unlike the UK, our MOT, we have MOT centres, a number of MOT regional centres, whereas I think in England, in Wales and Scotland, you still bring your car to a local garage for MOT, but we have regional MOT centres, and they were stood down during COVID. But the MOT centre in Belfast has given up their premises, so there are 5 lanes really of traffic go through, which has been absolutely ideal for our testing. So we have a drive-through testing facility by repurposing that MOT centre. Yep. And we have swabbed around 6,200 staff in that MOT centre since it opened back in April. That has been, a fantastic facility for us. We have tested over 20,000 patients and 12,000 staff, of which 2,200 people have been positive. So testing, we are limited, like the rest of the UK. There's always a risk of the reagent capacity, but we have now in the region brought in veterinary side of the veterinary department, Department of Agriculture, who are also providing tests, and we have a private provider. And I suppose discussions are now happening around the testing for the tracing, for example, and if we have to test people who have had COVID in terms of the antibody testing. So we're expanding the testing for antibody testing. So plans are afoot for that. PPE, I would say, in terms of staff, is our number one priority, and that continues to be a great challenge. We have fared, I think, better than most of the nations in that respect. And I know actually there has been a lot of collegiality between nations, and we have been provided some of the stock in low supply by our nations, but we've also lent or given some PPE equipment and other products to other nations. We have come dangerously close, I suppose, in Belfast Trust to run out in some of our products, and some of the other trusts have been very quick to lend us supplies where maybe our initial allocation methods weren't really keeping pace. I mean, it was difficult. We've done a lot of complex modelling since then. But whilst we've been close, nobody has ever run out, and that really has been testament to the work of our Centre of Procurement Expertise, who have kept us all right. And as I said, for other trusts who have helped us out when we've been low. I suppose, and when I say it is still a risk, depending on how demand goes, people would say we might have 2 or 3 week supply of some of the high-end FFP3 masks, for example. If demand does not materialise, I suppose, as it has so far, then that is probably more than in a few weeks. But for some of those products, particularly those masks and the surgical gowns, for example, they are still in very short supply, and there is, we are getting by, but there is a nervousness, and that also puts pressure on us in terms of restarting, particularly in the surgical gown. So we're very conscious of that in our planning. In terms of other things and staff support, we have worked very closely with our trade union colleagues, and in fact the chief executive meets the trade unions with the director of HR every week. We very early in this whole journey in March made parking free for all staff, because we have a huge problem with parking on our sites, but because of the footfall and less vehicles, we were able to provide car parking free. We also provide free meals for staff. We did work with a local hotel chain, and we have a city centre hotel that is home to our staff, some of our staff, on a short-term basis where they can't go home because they're symptomatic or they're trying to shield people in their homes, or between shifts where people travel long distance and they're doing long shifts. So that has worked really well. We had local schools and a local university teaching college made their showering facilities open for us, so where they were near our hospital sites. And we have also provided helplines. We recognise, like everybody else, that our staff are under enormous pressure. A lot of them are scared and anxious. They're often working very long hours, and whilst adrenaline got us through the early months, people are very tired, and there is still that level of anxiety and there's sense of loss. So we have organised increased access to occupational health and psychological support. We have a number of helplines, psychological helpline. We have a new occupational health advice line that was set up at the beginning of March. And I think that has provided advice, our staff there, to about 6,000 staff, actually. We feel that communication has been the key to our success. We have daily staff briefs. We have briefs to local politicians. We have podcasts on a weekly basis about, particular topical issues. And we have regular team updates, and all really under the umbrella of a very small and very active COVID management structure. But it's been very clear really where the responsibilities and accountability, and that communication, I think, has been key to success.
Absolutely. So just thinking now about the future, you've already mentioned that there's been a few lessons to learn and some good practice you want to take forward. One of the things that's been mentioned a lot, is in the news a lot, is the mental health impact of COVID-19 on the staff, as you mentioned, but also on the wider population. And mental health services are potentially going to see a surge of their own coming. Is that something that you're preparing for as a trust as well?
Yes, I mean, we're very conscious that we have, because we have the full gambit of mental health services in our trust. So we have an adult acute mental health unit on the Belfast City Hospital site. We also have an adolescent mental health unit, and they have remained open throughout. We have an emergency assessment unit, and then we have a number of secure mental health units on one of our community trust sites. We have inpatient services remained operational. As I said, community mental health teams, obviously, because of social distancing, and these are vulnerable people, and there's higher levels of anxiety. And we haven't been able to maintain the level of face-to-face contact, but they have been very imaginative in their use of virtual consultations, and we have had comprehensive telephone triages, for example. And we are building up now in line with government guidance to more face-to-face. Our inpatient psychological services have been continuing across hospital sites and have actually been growing. We've put more support into that, and that would include our mental health and learning disability services, as well as elderly and acute care. Outpatient work, like our acute outpatient work, has continued using a mix of virtual and phone therapeutic delivery. And we've set up helplines, additional helplines for family and patient support. And I suppose what we're now trying to do is those are coping with those with immediate psychological distress and concerns. But we know that probably the levels of anxiety will increase, and there is a future need there. So we are trying to keep more in touch with patients who we perceive to be the most vulnerable. So we're also exploring the delivery of psychoeducational groups and training, and the use of webinars and facilitated sessions, because sometimes that just one-to-one telephone conversation just isn't going to be enough. And as you said, that's for our patients and our users. And it's wider than mental health. We have a lot of vulnerable children, a lot of vulnerable people with learning disabilities. Our day centres have been closed. The schools have been closed for children. All of those services, whilst we have kept, in touch with the most vulnerable, and we have had limited, but we have had some visits out to children on the, child protection, those on the edge of care, those new referrals. We need to very quickly, providing the balance is right, start those services again to make sure that there isn't a longer term impact on our most vulnerable. And then, as you said there, our staff, obviously, as I said before, staff have been very anxious. There's been personal loss for them. There has been, long hours and very challenging work, fully masked in areas that some people is new to them, and they've had to have extensive training for. And we have had set up additional helplines, but we are very conscious that we will need to build, and we're going to hopefully mobilise some of those partnerships that I talked about earlier with the voluntary sector and with some of our partners in other sectors to provide that psychological help and support to our staff and to our volunteers and the many carers that we have out there who this has been very difficult and very isolating for people. We've had people in learning disability. We have elderly learning disability clients who have not been able to go to day centres, and very often their parents are very elderly, and those, that has been an extremely difficult burden for them now, and we have kept in touch with those people and have offered a lot of support. But it will take more time for them probably to normalise back into their normal day-to-day activities. So we have some activity-based support already gone out there. But again, as I said, we need to quickly build that up.
So, Maureen, what are your thoughts about the next few months? What do you think is going to happen and what are your priorities?
Okay, well, I mean, I suppose our current focus is twofold, and some of this I already covered. We remain prepared and ready to adapt quickly again for second surge. So our Nightingale Hospital, as I said, we've kept beds free, and we know, staff will be able to mobilise themselves to stand that up again. But at the same time, we're also trying to switch other services back on and develop those. So we has, as I said earlier, been doing emergency surgery, but we need to expand that for other time critical surgery. We need to reopen our day centres, starting with the most vulnerable of our users, and to recommence other community services where people really need that normality in their lives and the support that they need. Obviously, ensuring a safe place to work for our staff remains a priority to us. So in terms of our restart, we will not restart until we know it's safe to do so. And there are a number of limiting factors. One is the extent to which we can socially distance and comply with the PHE guidance. And work is currently going on to redesign buildings and service pathways. We are looking at, one way in, one way out. For example, we are moving people around, and we will continue to try and support different work patterns so that people can work safely. And PPE, as I said earlier, is a huge constraint, and so we need to keep an eye to a future supply whilst we're turning things on. So there is very complex modelling, and we keep a very tight eye on that. I think, as you mentioned earlier, and it has happened across the UK, there have been some really, innovative initiatives and some real learning from this. And our directorates have felt empowered, and they are currently looking at some of that good practice, and they're deciding which of the temporary changes they want to just now adopt permanently. And there will be, that will be, I think, a very exciting time for us as a trust. We do need to keep our focus on delayed discharge, on stopping delayed discharge, because we can see our ED numbers going up. It isn't going to be long before we're into those crucial winter months again. And some of the things we've done in our care of the elderly and our use of acute geriatricians and our new pathways in that area, I think we really need to develop so that our flow through the hospitals and through the community, and really with right patient, right care, right time, in the back of our mind. I mean, that has been better for our patients, and we need to develop on those. So I think, that's probably, the key short-term work for us. I think there's also going to be quite a focus across the whole NHS and the health and social care on our, needs for sustainable workforce and funding. And I think that really has come to the fore. And I think we have been operating, when some people refer to, in the red zone for a while now. And I think, it's time for a more public conversation. And I know, it's particularly in Northern Ireland. My own trust accounts for about 1/8 of the whole public sector budget in Northern Ireland, and health accounts for over 1/4 of the budget. So public sector spend is a huge element of our spend. But alongside our transformation agenda, we really do need to look at how we fund and provide a workforce in a sustainable way. We have exceptionally high vacancy rates amongst our nursing staff, for example. So that hasn't helped in a situation like this. We have staff have retrained and have, stepped up to the mark, but the vacancy rates were, a real risk to us starting off in this.
Thank you so much for talking to us today, Maureen. That's been really interesting and really good to get a different perspective on how people have been coping with COVID-19 in a different part of the UK. So that's been great. Thank you.
Thank you very much, Sarah.
All of the HFMA's COVID-19 related briefings, blogs and news articles are openly available on our website, hfma.org.uk. There is no need to be a member to access these, so please tell your colleagues. We have also launched a forum where finance colleagues from across the NHS can discuss issues and challenges in a safe space. you can sign up via the link in the network section on our website. If there are particular topics that you would like future podcasts to cover, then please get in touch via our email address policy@hfma.org.uk. Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.